Conference will now be recorded. This conference will now be recorded.
The what? The one with this chair? Go in the hallway, you want 3? Yeah. Yeah, so anytime you use a stair chair, you want 3, right? Because what you want is a person up top, a person down bottom, and then a person guiding the person going backwards. What about going through hallways and stuff? Yeah, you always want to have 3 because somebody's going to be going backwards. And so you always want to have 3. Anytime you have somebody walking backwards like that, a third person just to kind of guide that person so they don't run into things, trip over things, stuff like that. So, all right. So we're down to the last couple of absolutely mind-blowing chapters. This is going to be over medical, legal, and ethical. And then the other one is communications and charting. Becca has a big thing about charting. Like we said last time, if you don't chart appropriately, that's the easiest way to get yourself in some hot water. So keep that in mind. This will touch on it, but the next one will be good. And then next week we start into all the fun stuff, and that's when the grades start trying to separate, because that's when stuff gets a little more interesting. So, all right, our objective is we're going to differentiate between scope of practice and standard of care, review legalities in regards to pre-hospital care, understand patient rights and covering all bases with refusals, define morals and ethics and how they affect EMS. So your scope of practice, like Becca said last week, everybody in EMS has a scope of practice. That doesn't mean that your scope of knowledge. You always want to learn things, and you always want to try to gain what you learn in this class and keep moving forward. But just at a base level, you have a scope of practice that you work under. The NREMT model is kind of like the basic guidelines for everybody. And then each state has kind of, like out here, we can use paralytics and RSI people and stick tubes down their throat. In the state of Georgia, we couldn't do that. It's in my scope of practice to do that, but the state of Georgia didn't adapt it, right? So every state has their own kind of branch off of your entire scope of practice. But basically what it is your skills and medications that you're allowed to give as EMT. So make sure whenever you start doing it, if you stay in the state of Nevada, understand the laws in the state of Nevada and what you can do. Like Eureka County, they allow their AEMTs to give narcotic pain medicines because they don't have paramedics, right? So there's some things that you can do more and some things that you do less of. So just make sure you really pay attention to those levels. So
it's not only just state, it's also county.
Yeah. So they have in the state of Nevada, they have they call them frick.
I believe in that.
What's the name of that freaking, what's that word where you get like extra scope of practice in the agency? Variancy. There we go. So they have like different variants that you can apply for through the state that will allow different agencies to have different things, right? So that's how Eureka County, I think Wendover is the same way. Wendover can give narcotic pain meds as advanced EMTs, and that's not in the normal scope of practice of an advanced EMT. That's a paramedic level. Are you taking my stuff?
I'm trying to share the screen.
Stop sharing again?
Yeah.
Hate technology.
This one, right?
Yeah, should be screen 2.
Oh,
That is. Go right. That work?
Where do we find got that Chrome though?
So it'll be agency based. And so it just depends on whatever agency you work for as to what extras they have. And then just kind of the state website has like their full NRS list of things that you can do. And so you can get on the state website and they have like the full scope of practice of everybody. But then with the variants, that's just a county thing that that individual county would provide you with the information for. So it's kind of weird. Out here, it's a lot different. In Georgia, it was just like, this is what you get to do. Here you go. And then every county, like some counties could administer blood, some couldn't, but that was just them going out and saying, hey, we want to do this, this is why, and then they would get approval through the state, and then they could do that kind of stuff. So it's just really county. Whenever you sign on with that county, they'll let you know if you can do things above the normal scope of practice, if that makes sense. But just at a basic level, that NREMT model is just kind of the umbrella of everybody, and then you can kind of bounce off of that. So gets a little confusing. So the standard of care. So everybody in EMS has a standard of care, which is basically just if me and Becca ran a 911 call and we're both a paramedic, I have a standard of care in which I am supposed to act, right? If Becca runs the same 911 call, we're supposed to act in a similar manner when it comes to the care for this patient. If one of us deviates from that and, doesn't act to that standard of care, that's where you get into some legal issues, right? So what they'll do is if you run a 911 call and they come back and try to sue you, they'll look at the standard of care and they'll say, well, if I had another EMT run this call the exact same way, would they have done things in the same manner in which you did them? And if the answer is no, then that's when they start trying to file lawsuits against you and criminal charges against you. So everybody has a standard of care, which is just your expected level of care as a provider. And then your scope of practice, it's what you can do. And then the standard of care is how you should do it, right? So patient consent. There's two types of consent, express consent and implied consent. So express consent is if I walked in right now with Calvin, right? Calvin's awake, he's talking to me. Somebody called 911 because Calvin was sitting in his car too long at the Golden Gate. That happens. So I show up and I'm like, hey buddy, what's going on today? And he's like, what the frick are you doing? And I'm like, somebody called 911, they were just checking on you, right? Well, Calvin has the ability for express consent. So if I walk up to Calvin and say, hey man, like I just want to check on you, are you good? Calvin is able to communicate with me and express consent to evaluate him or not, right? Implied consent is on the flip side. Implied consent is if I walked up because Calvin was passed out behind the wheel of his car and I walked in and Calvin's still unresponsive, there is an implied consent that he would want me to perform the things that I can to help him in that manner, right? He's not able to communicate with me. He's not able to make sound medical decisions. So he has an implied consent that he wants me to help him when he's not able to help himself, essentially, right? So remember that because that'll come into play, especially when you're dealing with intoxicated patients, also mental status patients, and then patients that have an ability to make their own medical decisions. So being able to differentiate those two. So some possible exceptions to this, the life-threatening injury and illness kind of falls under the implied consent to a degree. Laws in EMS are very, very gray line. They can kind of make your head hurt. But when it comes to life-threatening injuries and illness, if you're unresponsive, unable to talk to me, then I'm just going to do everything I can to save your life and fix you, right? Minors who have children are an exemption to this. Under the age of 18, you're considered a minor in pretty much every state. So you're not allowed to make medical decisions for yourself. The difference is if they're pregnant, emancipated, or a part of the armed forces, they can make decisions for themselves. There's even a grayer area that states that if a minor that is pregnant has a medical concern with them, their parent has to make a decision for them. If it involves the child that she's pregnant with, she can make that medical decision. Clear as mud? Yeah.
Parents can consent to their children. Children cannot consent to themselves.
So, just, it's a lot, and it makes you want to bang your head through the wall. I've only dealt with this emancipated minor thing like twice in a decade. And they were both in the city of Atlanta. They were like 16, 17 years old. They were emancipated. They got all the paperwork, and they were like, "Yep, here goes my paperwork. I can do what I want." And I was like, "Cool, man. Hop in the truck. Let's ride." So,
Do they have to have that paperwork kind of like a DNR, like on hand?
it would benefit you and behoove you if they did, because if they don't, they're still considered a minor, right? Kind of same thing with the DNR. A DNR only works if I can see it. If you don't have the DNR, it doesn't really do anything for me. So, children and mentally incompetent adults. So their minors are not legally permitted to provide consent or refuse treatment, right? Unless they fall under those categories. And so any sort of treatment or refusal of treatment must be obtained by a parent or legal guardian. A legal guardian in some cases can be coaches, and that's where you're going to run into that most. That's what this in loco parentis thing means, right? It's in lieu of parents when the parents aren't there. So if they're in school, they're on field trips, if they're playing sports, any of that stuff, you have given that school the legal right to make decisions in case they can't get in touch with you for whatever reason. So last year we had a bus accident out here on the interstate. Everybody was fine, but that coach that was on that bus had legal care over those kids at that time because they were all under the age of 18. So,
How do you say that again?
in locos parentis, loco parentis, does that sound right, Kelvin? Like Latin. Everything's freaking Latin. I don't know. But all it means is in lieu of parents. So when the parents aren't there, loco. Is anybody Latin? Yeah,
I was trying to pronounce it and I couldn't.
I'm hillbilly, so yeah. So involuntary transportation. So out here we use legal 2000 form. In the state of Georgia, we use 1013 forms. And these are patients that are considered suicidal or homicidal. They are no longer allowed to make clinical decisions for themselves, and they must be transported and evaluated by a physician, right? So if you call me and you say, well, I'm going to shoot myself. Okay, cool. Well, now you have to go. I don't have a choice. You have to go, right? If you're like, no, freak you, I'm not going. Well, I have ketamine for that, and you're still going to go. So understand that when you're in this state of suicidal, homicidal ideations, you have given up your right to make decisions for yourself. Now, if you get over here to the hospital and you were just like really, really drunk and you start to sober up and you're like, man, I am so sorry. I didn't mean that. Like I was just having a bad time because I was a little inebriated. There's a chance the doctor will let you go. A lot of times this leads to a 72-hour hold. So they'll transport you from here down to Reno or Vegas or somewhere, and they'll put you in a psych facility for 72 hours, and that's what you're looking at. So these forms right here, ironically enough, cannot be initiated by EMS. But ironically enough, the sheriff's department can initiate them. I don't know why the sheriff's department can, but we can't, but they can. So if the sheriff's department goes out on you and they feel like you need to be legal, they can put a legal hold on you. It has to be finalized by a physician to be completely within the legal realm of things. But the sheriff's department can legal 2000 you and then force you to come into the ER. if you have a patient that is restrained, make sure that you're monitoring these patients very, very closely. Like I said last week, or on Tuesday, do not restrain these patients face down. There's a video running around somewhere that I'm sure I can find from, I'll say it's like Arkansas or something, where they had a guy that was being combative. They restrained him face down. He died. They got homicide charges put on him. So don't do that. It's no good. But make sure you're monitoring these patients very, very closely. Monitor their vital signs. Typically, what you'll see us do is we put one restraint down beside them and one restraint behind them. That way they can't lift up off the stretcher and like slam themselves against the stretcher. Backboards are great for restraining patients, but there's potential to cause damage to that patient if you do restrain them to the backboard. So just keep that in mind. But yeah, do not restrain these people face down, and make sure that you keep really, really good eyes on them.
I'm done chatting.
Huh?
You heard your poor voice, you want me to take over?
Yeah.
He's like,
I'm
please.
trying.
Thanks. All right, sorry, Bill.
You should be.
He's crazy, right, the whole time. I knew it. His poor voice. All right, so refusal of care. So if we're ever on scene, right, so our patients have a right to refuse care most of the time. So I say most of the time because if somebody is altered and they cannot cognitively realize like, hey, if I refuse, I'm going to die or whatever the outcome may be, they cannot refuse. So these are the calls where you are usually held most liable. So people are like, yeah, my cousin called 911. They came out and checked us out, and now they're dead, and it's EMS's fault. So people love to sue EMS, and it's usually over these kinds of calls. So first little check mark they need is they need to be legally able to consent. So if it's a minor, obviously the minor cannot speak for themselves. So the in loco parentis thing, guardian, parent.
Did say it right.
I don't even know if I'm saying that thing right, but let me try. They need to be awake and oriented. I put a star next to oriented because some people are like slightly out of it and they can still refuse. So the big thing here is that they need to be able to repeat back to you, I understand that if I don't get checked out, that I may die for XYZ reason. That's the big thing here. You want to make sure that your patient has mental capacity to refuse, right? So if someone is drunk in their own home and they call and they're just slightly out of it, usually these are the times that I call a doctor just so I can have somebody with more schooling than myself be like, hey, just so you know, this is what I got going on. You talk to the patient, and then from there they'll tell you like, yeah, it's an 8 or bring them in or leave them there, it's fine. So this is where like there's weird gray areas, and sometimes it can be hard to work around. It seems very cut and dry on a PowerPoint slide, but once you get out and you're talking to people and they don't want to come with you, it can get kind of weird. So the mental capacity, that falls under the fully informed as well. So if somebody's having a stroke, like their face is drooping and they don't want to come with me, and they're able to tell me what day it is, who's the president, but they don't understand that the stroke may kill them, and they're not able to repeat that back to me, we need to take them. That's how that works. So, and then we have refusal forms. Every agency is a little bit different. Usually agencies have lawyers that look over their refusal forms and change them every few years. But pretty much the gist of them is all the same. It pretty much just is in writing. The patient understands that we are not doctors. We cannot rule out underlying illness or injury that may kill them. And then it also says on there that they need to know that they can call 911 back at any time. So that sounds kind of like duh, but I always let people know because you don't get just one 911 call a day, and some people think that you do. So that stuff's all on the refusal form. I usually recommend at least reading through one of them so you kind of get the gist of what everybody's signing. So,
Have you ever dealt with a case where a child was hurt somebody who was intoxicated and was in loco parentis. Like, you know, child
Not
got
so
hurt
much.
at a birthday party and the parents can't really make those kinds of educated decisions because they are considered inebriated.
Not so much like in loco parentis. I've dealt with like some weird situations. So like, sorry if this offends anybody, but where I was from in Idaho, there was a cult. We called them the 2x2s. But they didn't believe in doctors. So we had a kid that was pretty messed up, broken arm. She had like partially like been scalped from a car accident. And so we got called because the bystander called us. Parents did not want her to go at all because they don't believe in doctors. There's actually a documentary, I think it's on like HBO, that they did about it because they found out the coroner was covering up like these kids' death, like this same group of people. So I don't know if anyone's in a cult in here, but I just say that. But anyway, so that ended up turning into like a whole thing. So we obviously had PD involved. PD was already on scene because it was a car accident. So at that point, PD needs to make that evaluation, and then usually we ended up transporting her anyway, because PD got involved and was like, hey, this is child neglect and abuse if you don't let us take them. But I'm sure that those situations are also like hit or miss depending on where you work or who you're working with. But like I said, like this is not like a linear thing. It looks very like cut and dry on a PowerPoint, but once you're in the situations, those decision making is like, okay, who do I need to contact? Make sure you're using your resources like PD, ESO, the doctors, family members even, like if somebody wants to refuse and they're like clearly gonna die, I like to get the family members involved and like, hey, how about you convince them to go if I can't, you know? It's not with me, with you guys, you know, those are things that you can use your resources with.
Like if somebody is refusing to go to the hospital and they're like super hypotensive, one of my favorite tricks is have them stand up because then they pass out for a little bit. I'm not oriented.
Yeah.
Now they come with.
Yes. And now you have
Use your
your
resources.
Yeah.
That is called our hard reset button.
It's called testing orthostatic hypotension.
Yeah, another one I had, I think that this was in Idaho, it was like right before I moved to Georgia. The lady kept going like hypoglycemic, her sugar kept dumping out on her. So we got called out there like every 2 hours because she'd be knocked out. And so we'd get her sugar back up. She refused, didn't want to come with us. She was alert and oriented. We couldn't make her come. And then finally, the last time we went out on her, we didn't wake her up till we were almost in the hospital. We were like slowly giving her sugar because she can't refuse if she's in the back of the truck. So, well, she can, but by the time she was awake and oriented, you can't have somebody that's like, I want to go to the hospital, and you get halfway to the hospital and they're like, F you. And then you're like, okay, here's the door. Like it's okay. Okay, so oriented, again, this is just touching on the mental capacity. You want to make sure that the patient understands the risks of refusal. So this, I was like probably 4 years into EMS before I completely grasped this, because I'm like, they don't know what year it is. They can't refuse, but that's not always the case. Another thing I want to touch on is, I don't know if it's already been in the power of attorney stuff. Has it already been in this? So there might be a slide on the power of attorney stuff. I don't remember. So that's where things can get a little hairy too, is whenever you're talking about a power of attorney. So sometimes people appoint like a family member to be their power of attorney. And then that family member sometimes thinks that they get to make all the medical decisions no matter what of that patient. That is not always the case. So if your patient is still alert and oriented and they're able to talk to you like I'm talking to you right now, they still have every right to refuse. Power of attorney trumps their decision making whenever they can no longer make sound medical decisions for themselves. So we've had like family members be like, no, they are going to the hospital, and the person's completely with it and doesn't want to go with me. That's still kidnapping, even though their power of attorney was like, you have to take them. So again, one of those weird little gray areas. So whenever you are dealing with a patient refusal, make sure you're conversing with the patient. Figure out why they don't want to come, right? So sometimes it's a money problem. Sometimes it's a I don't want to leave my dog home alone problem. Sometimes it's, you know, I have a wedding to be at or whatever. So if you can find a workaround in some of this stuff, I always encourage it, like, hey, you have someone that can come take the dog, can I call someone for you? Whatever the case may be. Because if someone's not going, I would be that person and be like, I don't want to leave my dog. So I always try and like find a workaround to help the patient out. So make sure you inform them of the consequences, the risks of refusal. And then if your protocols say to consult medical direction, obviously do that. Some protocols you'll see where they're like, you can't get a refusal unless you call a doctor. So it used to be like that at Grady for a while. So just make sure you know your protocols, and then contact family or friends. If someone's like really out of it and I'm like actually really concerned about the patient and it wasn't like, okay, you stubbed your toe, you don't need to come with me. They're like actually really sick. I don't like leaving them by themselves. So whether it's in like care of PD on scene or if a family member's home. And then I always like to make sure that they have a way to contact EMS back if like they need to. So sometimes people don't have access to like cell phones or something that might seem simple for us to have access to. Other people don't have access to that stuff. So I always like to, you know, maybe get social work involved or whatever.
So does getting a patient's refusal signature release you from liability?
No.
Good.
Very good, very good. There will be a test. Okay, so DNR forms, physician orders, they're called POLS forms, POLST. So these are legal documents that speak for your patient when they cannot speak for themselves. So if you ever have a patient that is in cardiac arrest and you're presented with a DNR form and it is signed and up to date, I believe they expire like every 6 or 12 months or something.
6 months.
They need to be re-evaluated by a physician and re-signed. So make sure whenever you get handed one of these, I have a picture of it on there. So if you get handed one of these, make sure that it's up to date. It tells you on here, like attempt resuscitation, yes or no, do not attempt. And then sometimes they have different orders on there, like they don't want certain medications given or they don't want to be intubated. But do remember that DNR does not mean do not treat. So if someone's in full cardiac arrest, their heart's not beating, they have a DNR form, I'm not going to start compressions on them. But if, say, they're really sick and their blood pressure is really low, or they're running a bad fever, or they broke their arm, I'm still going to treat the patient. That seems like common sense, but sometimes, what? So make sure you're still treating your patient, you're still making them comfortable. Sometimes you might get handed like a living will. Another thing that you might run into like in the field is the patient doesn't have like a real DNR form, but the family member will, like the close family member will be there while you're working a cardiac arrest, and they'll ask you to stop. Like, okay, Mima's 97, she's lived a good life, like this isn't going her way, like you guys can stop. Remember, if you ever do that, you need to call a doctor and get orders to stop. So, yeah. I think they're, okay.
So what happens if that is expired? And they
The
still try to-
DNR?
Yeah.
So what I would do personally is I would start BLS CPR. So I wouldn't go through the motions of drilling their leg, giving medication, sticking a tube in their throat. I would start compressions and I would contact a doctor and say, hey, they have a DNR here, but it's expired by however long. This is what they wanted before, and then it's up to the doctor. Like, yeah, go ahead and stop. Most of the time, doctors are pretty reasonable whenever you talk to them on the phone. Kind of got to be a salesman a little bit, but you know that's what that patient wanted up until that point. And so if it's like for whatever reason, if the doctor says transport them, we still transport them. We still do the full treatment. So. That's one of those things, like we work under a doctor's license, so, you know, we always contact another doctor because they'll give us direction.
Is there any sort of statute of limitations when it comes to expired? So let's say it's over a year expired. Would you still call a doctor and be like, hey, you know, a year ago, this is what they wanted?
Yeah.
think that kind of falls into the family and them thing,
Yeah.
right? Because like, you know, if the family's like, hey, like they got this, like this is what they wanted, and you look at it, it's like a year expired, be like, okay, well, do you still want me to uphold this? If the family's like, yes, like she still wanted this, just call a doctor and be like, hey, this thing expired a year ago. The family state that they want this to uphold, like, you know, blah, blah, blah. I've never ran into an issue with it where I've had like a doctor that's like, frick that, like you're bringing them in. Like most doctors are like, yeah, man, cool. 97-year-old stage 4 cancer, BMAW can go see Jesus now. So
I've ran into it more the other way where I have like a legit DNR and the family's like, never mind, do everything. I ran into, yeah, grandma's a fighter, and you're like, grandma's a skeleton.
42 pounds.
Yeah.
Grandma stopped fighting 5 years ago.
Yeah, we ran into that more times than the opposite where it's like expired. So usually that is like one of those things that we work on BLS anyway. Yeah, there's some people just don't understand like once you die and we get you back, if we get you back, it's not just a reset everything. Like you can still, they're still fighting stage 4 cancer once we get them back. And now they're dealing with other things. They're probably going to live on a vent for the rest of their life. So however long that may be. So that is a good question though. And usually the answers to those kinds of things is like call a doctor. If you ever have like concerns or questions about like legal things like that, give the doctor a call. And then document very well the doctor that you called, what you talked about, what they gave you permission to do. So, negligence. So this is something that should have been done, but was done incorrectly. So, or not done at all. So like if I know Chaz needs oxygen because he called and I'm like, yeah, I know he needs that, but I'm not going to give it to him. That's negligence, right? So whenever they're trying to prove negligence in court, they have to prove that the EMT had a duty to act. So there was no substantial like breach of like, okay, I physically couldn't put oxygen on him because he was punching me in the face. Like I had every opportunity to do this and I didn't do it. The standard of care, usually whenever it comes to like the legal side of things, whenever they are dealing with like standard of care in like a courtroom, they bring in expert witnesses. So like my old paramedic instructor, he was a like court person that would go in and testify with or against like paramedics in like wrongful lawsuits. So they would ask him like, hey, you're a paramedic, you have this licensure. Would you have done this or would you not have done this? And he has to prove like, I would have done this because of this, this, or this. So those are things that get brought up in like a courtroom and they have to be proven before you get charged with anything. And that's how they usually go about it. So the proximate causation, so if your patient suffered harm because of what you did or what someone else did or what you didn't do. So like if I didn't put oxygen on Chaz because he needed it and now he has a hypoxic brain injury, that falls back on me, right? Because I knew that he needed oxygen. Or I should have known because that's in my very basic level of training.
About with instances like CPR, sometimes ribs break.
Yeah, so that comes back to like, what's the name of that? Well, Good Samaritan Act.
Oh.
Yes, thank you. So that goes back to your Good Samaritan Act. So if you are working and you're doing it out of basically like the goodness of your heart, like you know that this needs to be done, you're doing CPR and they try to file like a lawsuit against you because you broke a rib, that's pretty easy to dismiss in court. Like this is how CPR works. Ribs sometimes break in CPR, but yeah. So I wouldn't be too concerned about all that. I mean, obviously it's like something that's going to happen eventually. But like I've never had a patient in the 10 years of doing this that like survived and been like, she broke my ribs, I'm suing her, you know. So that's never been a thing that I've dealt with. So I don't think it's a very common thing. So this rest is for the liquid cord. The thing speaks for itself. So yeah. So it's a legal concept important in negligence cases. So it's like, here's your standard. This is what you've been trained to. Did you act to what you've been trained to or not, basically is what that's. So, our duty to act is our obligation to provide care to a patient. So, if you are driving down the road and you are off duty, you're driving your personal car, and you're not wearing any kind of EMS, nothing, and you see a car flip in front of you, now that you have your EMT license, are you obligated to stop and help that patient? Okay, good. Glad we cleared that up. So it's not always clear, but if you are off duty, now if you do stop and help that patient and you act within your scope of practice, are you liable for anything done to that patient? Yes, yes you are. Now, if I am an EMT basic or an EMT now, and I pull over and I am helping somebody and I'm like, well, they need to be needle decompressed and I need to put a tube in their throat. And I just happen to have this amiodarone in my pocket and I'm going to give them amiodarone. What do you think is going to happen? Yeah, bye-bye license, yeah, and most likely lots of lawsuits. So even as a paramedic, if I was just off and this is somebody on the side of the road, obviously I don't carry medication, but you will run into rescue Randys that are like, here's my box of tube stuff, and if I ever run into somebody that needs intubated, I'm gonna do it. Like, good on you. I'm not gonna put myself in that situation. I carry a BVM in my car and some stop the bleed stuff, and that's what I carry. If someone's not breathing, I'll breathe for them, but I'm not gonna go sticking tubes in throats. So if that usually happens, you're not in your own jurisdiction. You're not licensed to practice in that jurisdiction. So that's just how that goes. Okay, so follow your local laws and protocols, and then follow your own conscience. So don't be the rescue Randy, like that scene in The Heat where she's like, when they prank this guy, sticks a like straw in his throat. Don't be that person, please. And it's happened. I say that because it's happened. It's not just a movie. That thing really happens. Used to be a guy that ran around Atlanta. He was a freaking EMT, and he would steal stuff from his work and carry it in his personal car and wait for stuff like this to happen. Okay, abandonment. This is pretty cut like this easy, right? So abandonment, don't abandon your patient. So one thing we did run into in Atlanta, and they would love to say, well, you're abandoning your patient, but we would show up to the hospital. The hospital had 30 minutes to get our patient registered. What we would do in Atlanta is if they didn't get us registered within that 30 minutes, we had already given a report to a nurse. We could leave our patient in front of the nurse's desk. That's not abandonment because they are on hospital property. It's EMTALA law. The hospital has been given a receiving report of what's going on with the patient. Now, where that changes, if I was just to pull up without giving a report, dump the patient, and then run away, that's abandonment. So you need to make sure you're giving a report. You're not leaving your patient. So the other thing here is you need to give the patient like transfer care to a personnel of equal or greater training. So as an EMT, that could be to another EMT, to another AEMT, to a paramedic, an RN, CNAs. We cannot give report to a CNA. There needs to be an RN on scene or an LPN, but we can't give a report. So like we go drop a patient off at a nursing home, we have to give report to an RN or an LPN. We can't give report to a CNA. Same thing for EMT basics, I believe, right? Is that all the same? Yeah.
Paramedics can't give it
To LPNs, it's RNs only. Okay. Corrected. RNs only. What about EMTs?
I think EMTs.
Can to LPNs, but not CNAs? Gotcha, okay. I haven't given a report to a nursing home. So here's the Good Samaritan law that we were talking about. So grants immunity from liability if you act in good faith. Again, don't go stabbing straws at people's necks, please. But if you see someone go into cardiac arrest, what have you, and you are acting in good faith to help that patient, you have immunity. some scenarios. CPR guy. All right, this is where I start learning names. So I'm just gonna point it back there. Say your name.
Jessica.
Jessica. All right, Jessica, you arrived at the scene of a patient in a cardiac arrest. The family states that the patient has a DNR, but they cannot find it. How should you?
Start with compressions and then call the doctor.
I like it. I like it. So BLS CPR. I don't go doing all that other stuff. Call a doctor.
The answer is always call.
Yes. All right. All right. What's your name?
Yeah, Marissa.
Marissa. I will get names one day. It's usually like the last week of class. I'm like, I know it. What is his name? Okay. So you are off duty and arrived to the scene of a vehicle crash. Police and EMS have not yet arrived. Are you legally obligated to stop and render aid?
No.
All right. So confidentiality. So basically, don't go talk about patients, right? If you are not giving a report to somebody that you are handing off the patient to, don't go talk about them. Don't be like, oh yeah, I picked up Marissa down the street and she broke her toe and told me she has herpes or whatever. Don't do that. Don't post on Facebook. Don't take pictures and then post them on Facebook.
Don't put them on Snapchat stories.
Don't put them on Snapchat stories. Just don't do it. So don't write it down. Don't talk about it. If the patient that you are, or the person you are talking to does not have direct, like, you're not directly treating your patient, don't talk to people about your patient. So, or else the HIPAA codes.
A couple of things just to touch on this, because people love filming. People love, I know if you watch TikTok or you watch YouTube, they got those public servant auditor folks that run around and stick cameras all in people's faces and stuff. The general public is not bound by any HIPAA. So if you're on a crash scene or you're out in public or whatever, and somebody runs up and films you, you cannot turn around at them and be like, you're violating HIPAA. They're not bound by HIPAA. Only you are. You can get SO involved and have them removed from the situation, but you have no legal grounds to stand on to tell them that they're not allowed to film. My suggestion would be to put them on your stretcher, get them to the back of your truck, and get them out of the general public view. We actually had a rule in Atlanta where if you were working a public scene, you weren't allowed to stay on that scene for more than 10 minutes. For that reason, because people love to be like, oh God, I watched this 90-year-old lady get CPR and now I have PTSD. There you go, shut up.
They
So-
also filmed somebody dropping a patient.
They did. They filmed one of my buddies drop a patient, but it wasn't actually him. It was an Atlanta fire, but our Grady ambulance is all over the side of it. So they're not bound by HIPAA. They do not care. As far as HIPAA goes, like Becca said, when it comes to the legal obligations of this, if Becca's not on my 911 call, me and Calvin run a 911 call, and I come back and tell Becca about that call, I've just violated HIPAA. Right? That's how easy it is. Right? So just be mindful of that when you go home and you hang out with your friends and you hang out with your family. If we all go to the owl afterwards, after we ran the 911 call, like when the guy got shot down here at the bar last year, we all went to the Colt for breakfast. We were sitting around, and the first thing they did was walk in there. Y'all ran the guy that got shot? Well, they got shot. That's crazy. Wow, I didn't know who did that. So just be mindful of that. It's a small town. People love to talk. Don't go into the owl. Don't go into the cold being like, bro, you did a good job. Yeah, friggin' stick your finger up his butt. Yeah, good. Don't do all that.
Don't stick your finger up someone's butt first.
I don't know.
There's a doctor around here that tried to like hail me and Becca out. I was like, listen, doc, you can explain what you're doing. I don't care. I'm not gonna stick. I'm not doing that. I'm gonna pay enough for that. So, but just be mindful of that. It's very, very easy to get wrapped up in these laws, and since now people love to walk around and film stuff, you will end up on somebody's camera and they don't care. People love riding down the road, filming you and stuff. Just let them do whatever they're gonna do, but watch yourself, because they'll run into you too, so.
Basically so the reason we're able to do like case studies and stuff like that is because there's no patient identification information in case studies. So you'll read things that'll be like, present a 24-year-old male presented to the ER with complaints of chest pain or whatever, and they'll give you this whole case study. That's one thing. And that's okay. Like if the patient's name has been redacted, all that stuff, there's no way to identify who it was. That's not a breach of HIPAA. But if you go in and you're like, Calvin went to the hospital over here and he had complaints of tum-tum pain, like that's a problem, right? So, in cases like we're gonna do a case, like a case study, we have permission to do it from the patient.
So for the call you just went on, if you were to say patient 32 male, could you then share the, like, not descriptive, like identifying descriptors, but
You can talk about calls.
Yeah.
Without descriptors. If I was like, yeah, I went down here to 123 John Street to see freaking old Billy Bob down here because his freaking toe was hurt, what would you do for this patient? Right? We're doing a case study, right? Because I'm trying to educate y'all, like, what would you do for old Billy Bob's broke toe? Right? Well, me saying Billy Bob down here on 123 John Street, now I've just given you all his information.
Yeah, no addresses, no names, no birthdays, no license plate information, none of that. Cool.
but I can talk about like a male presented with chest pain.
Yeah, like you'll see in one of the later slides, we have pictures of like CTs that were taken of patients that we had. We had a dude freaking double tapped in the forehead right here and still talking to him. And so we have a picture of a CT scan up here. But for the information I just gave you, you have no way of identifying that patient unless you know somebody personally that got shot twice in the forehead. Most likely it's not this guy because he was not around here. So like that's like you'll see stuff like that, but it's different whenever you bring names and addresses and birthdays into the equation.
Same thing, you'll see us post pictures of the helicopters if they're like taking off on our Facebook page, stuff like that. There's no identifying marks as to what that patient or who that patient is, so we can do stuff like that. Right? That's how we get away with that. But if I walked up and like snapped a picture of the guy's license plate, you know, and half mangled car, and the guy's laying out of the car, freaking noggin half taken off, and then freaking I posted on Facebook, and then you know one of y'all are like, "Oh, that's my cousin." I'm like, "Frick!" So now we got a whole another set of issues. So.
Yeah. So if for whatever reason information about the patient does need to be obtained, it needs to be obtained first. So legally, they have to go through the whole system. They don't just go handing out your paperwork at the hospital.
So it can also be as simple as like around here, you'd be like, oh yeah, I went to a Kia rollover.
Yeah.
As simple as that.
Yeah, that's the thing about small towns is like you could literally be like, oh, the white car with the one blue door, everybody knows who that is, right? So like don't be talking like that. So, you could say I went on a vehicle rollover. That's one thing. But yeah, especially small towns. That's where it gets really everybody knows everybody. All right, so medical identification devices. This can come in many forms. So bracelets, necklaces, ID cards in their wallet. I have seen tattoos that tell you like what's going on with the patient. Some of them, like a blue circle means they are diabetic. I learned that. I didn't know that was a thing, but so.
Sometimes you can look in their phone, they have like that little emergency button.
Yeah.
On their home screen that'll have like a list of their medications and like their past medical history.
I think you gotta try and unlock it. Yeah, so if you hit emergency and then medical ID, like all the information, all the history. Some people fill this out. I do, but all my emergency contacts, my blood types, all in there. So keep that in mind too. That's a good way to get some information sometimes. Because not every patient is able to talk to you, unfortunately.
Just because somebody's dead doesn't mean their facial ID in their iPhone.
Yeah, apparently their eyes have to be open.
It will work though.
Their fingerprints.
Their fingerprints will work too. So if you do get that somebody's stuff,
Okay, so organ donors, this is kind of weird out here because the way organ donation works is they have criteria that the patient needs to meet. You can't go out on somebody that's been dead for 4 hours and then go harvest their organs. That's not how it works. So they have a hotline that they call here at the ER, and it's like basically that patient's beyond like help, but they're on a life support. They need to have like a pulse up into a certain point. So you can't just be like, oh, yep, picking people up with shovels and like, go donate their organs. That's not how it works. There's a whole process that goes into it. For us out here, we don't really look at, you're like, oh, yep, they're an organ donor. Let's do everything we can right now. I mean, we're going to do everything we can, but like, if we go out on an obvious death, like an obvious car accident, like trauma and like deaths in trauma, we don't really work them because the chances of getting them back is less than 1%, especially if they've died like before we got there. So it's not like we're going to do more than we would for the average individual because they have an organ donation card. If that makes sense.
I
That
hear
sounds horrible.
it's just a discount on your license. If
Yeah.
you die, ain't nobody getting your organ.
Yeah. There's
Unless you die in Reno.
processes, there's very specific situations in which your organs will be donated in a place like Battle Mountain. And it would be like, you're over here at the ER and some doctor hasn't transported you out yet and
I don't even know how
It's
that would
very
work, because
specific,
they
yeah.
gotta have like a surgical team ready, and you gotta have, it's extensive. They would do it in Atlanta. Most major cities, you deal with the organ donation, but out here, the chances of anybody actually donating anything is slim. Unless you happen to die in a wreck in Vegas or here, or in Reno.
yeah, usually it's close to like your trauma centers. They have organ harvester surgeons. And if you ever get a chance to like go in there and watch one of those, it's actually pretty cool. Like they're very respectful to the patient. It's a cool thing. I mean, it sucks, but that's. All right, so safe haven laws. You've all heard of the people dumping their child in a dumpster outside of a hospital. That's not how that works. So they need to be handed off to somebody or in one of these boxes. You can't just like ditch your kid in a bathroom and be like, oh yeah, safe haven laws. That's not how that works. So they have to be in Nevada. The law is less than 30 days old and has not been abused. So after the baby has been delivered or dropped off, they do an evaluation. If the baby has been abused, then at that point, it's not like the mom or dad or whoever is not liable. So they have these boxes. I don't know if you guys are familiar with these. Some of the fire stations, not around here, but there are some fire stations and EMS stations that have these boxes. So the mom comes up or whoever comes up, opens the door, an alarm goes off inside the station. They have like a less than 3 minute response from the dispatch, because sometimes if the fire department's like not on scene or like they're running another call, they're not in the station, it sounds an alarm in the building and it sends information to dispatch. So dispatch can get over the radio and say, hey, the safe haven, box has been activated. And then in there, it's all temperature controlled. There's like a blanket or whatever. So then it opens from the other side. So it's like a two-way. And you can't open both doors at the same time. It's one or the other. So mom comes, doesn't want the baby anymore. Baby in, alarm. And then they have someone on scene within 3 minutes, is what they say. They claim. So, crime scene we talked a little bit about on Tuesday. So make sure if you're working a possible crime scene, shootings, overdoses, any kind of domestic violence, or not domestic violence, just any kind of violence. Make sure that you're not stepping on crack pipes and all that stuff, because you'll be yelled at. Yeah, they get really mad if you step on their bullets. Don't be like, oh, I'm going to save this for later and then stick it in your pocket. That's disrespect.
They get real mad about it. Like, you got 67 bullets out here. This one is gonna solve your case? Highly unlikely.
Don't not treat the patient, because it's a crime scene. Obviously, if you need to move stuff, move stuff. If you need to readjust something, but don't go like walking in and being like, oh yeah, this crime scene's cool, look at this. Like, don't do all that. Not necessarily. So,
Most important part is if you move or touch something, just let the cops on scene.
yes.
Because they're a lot cooler about it than you can touch stuff. Why is this over here? Doesn't make any sense.
Typically, you won't see it out here, but if you go work in a bigger area, they have like a sheet they fill out. And so anybody that went inside that crime scene has to fill out the paper, with, like your name and stuff on it. So that way they can keep track of who all's been in and out. So if they find like a rogue fingerprint, like my fingerprint's in the house, they're like, we got that bastard. And then it freaking pops up and it's Mike Guggenheim. They know where it comes from. So.
Also, like if you're dealing with a patient that has like bullet holes or any kind of like even sexual abuse, make sure that whenever you have them like change their clothes or take them off, you're putting them in like a brown paper bag, like a breathable bag, because you want any kind of blood or anything to dry as it is on the clothes. Whereas like if you put it in a plastic bag, it'll like rub it around. So that's a big thing. Usually you carry like brown paper sacks in the ambulance for that reason, because that's all evidence as well. And then again with like the sexual assault cases, usually like your patients are gonna want to take a shower like immediately, because what happened to them, and for good reason. But try and get them to not do that because you don't want them to wash things off that could be evidence. So, all right, special reporting requirements in the state of Nevada, pretty much every state that I know of. I haven't heard of a state yet. So as EMS providers, you are mandated reporters. So any kind of child, elderly, domestic abuse needs to be reported. If you are suspicious of like human trafficking, any kind of like sex trafficking, that kind of stuff, any kind of sexual assault, it needs to be reported. Now, reporting is not like I'm dropping the patient off at the ER and I tell the nurses like, hey, I'm suspicious of this, see y'all later. That's not how that works. So you need to make sure that you're letting the officers know. You need to get in contact with your local sheriff's office or PD. And then there's also websites that you can go onto to report this stuff. And I have links to that in later PowerPoints. We go more into detail about it. So just know that if you run into something like this, that it needs to be reported. And even if you're like, I don't really know, I'm going to report it anyway. It's not like they're going to come back and be like, you reported this, you're a crappy person. This really wasn't what was going on. They're just going to say, thanks, have a good day. So if you're ever suspicious of it, Atlanta was it was the capital of human trafficking.
Yeah, the Hartsfield Jackson Airport is the more trafficked airport in the world.
Yeah, in the U.S. So that was something that we were trained to like identify. And usually it's like they have their handler or whatever, and they don't let them out of their sight. Like, we'll talk about that later more in detail. So, restraining of patients, whether that's chemically, if I'm giving them drugs to go to sleep, or if I'm physically restraining them because they're fighting me or hurting themselves, we usually notify PD of some sort. Now, I say notify. I'm not going to say I'm requesting officers on scene and then wait for them to get on scene and then restrain them. I'm going to notify them, but then I'm going to restrain them because I don't want the crap beat out of me. It hurts. I don't like it. So intoxicated person with injuries, usually that kind of stuff, any kind of injury call, most of the time out here, anytime out here, the sheriff's office is going to be on scene with us. So that makes a lot of this a lot easier because they're already on scene. But you might run into places where this isn't a thing, like where officers will be on scene with you. So make sure that you're reporting it.
When you use your brain, if a drunk guy fell, scraped his knee, but you don't have to call the sheriff's department. But if you roll up and there's some drunk guy laid in the alleyway, it looks like he just went 6 rounds with Mike Tyson and nobody's around, that's something that needs to be reported. So.
All right, so morals and ethics. So your morals are your personal opinions, and then your ethics are the standard of a behavior for a profession. So your morals might be like something as simple as like this guy's drunk and he just killed this family of 4 because he was driving drunk. I don't want to treat him. That's like a moral thing. Whereas ethics, I'm still going to treat that patient. He's still a patient. I'm going to treat him as I would anybody else. So that can be kind of a hard thing to set aside sometimes. It is a hard thing to set aside. But just know that you are still held responsible for treating that patient.
You will not be able to sit in front of a jury and say, well, I didn't do this because that guy killed that family. They don't care. They're still gonna lock you up for not doing the things. So.
So other ethical expectations, obviously, whenever we chart something, we need to be honest about it. Don't go put in there like, yeah, I gave this medicine or I did this whenever it didn't actually happen. And then don't think that by you not putting it in your chart that you're good as well, because that can always come back on you. So like say I gave you medicine, I'm like, oh, that was a bad medicine. I shouldn't have given that one. I'm just not going to put it in the chart. That can come back on you. Obviously, we're refraining from harmful actions. Not going around punching folks in the face. Most of the time. Just kidding, they started it, but that's what they started. And then assist others to learn your profession. That's a big one too. Like to me, obviously I'm standing up in front of you guys teaching you today, but I always feel like teaching the next generation of EMS is more important than anything I'm going to do on the street today. Because I want to do what's best practice for my patients. And obviously any other provider that I'm like assisting in this process of working EMS, I'm going to try and help you guys do the same thing as well, right? So that's a huge thing for me, like personally, but make sure you're reporting misconduct. And then again, to treat all patients fairly and justly, just like we were talking about. If you're dealing with the drunk guy that killed a family of 4, you're still going to treat him like you would the lady sitting in the front seat of the car that he just killed all those folks. It sucks, but we got to do it. All right, what questions do y'all have? No questions. Perfect. You're good. Oh,
For the, whatever you said, the family could ask you to stop doing CPR on their grandma or whatever?
Yeah.
Would they have to have the power of attorney to do that, or would they just tell you to stop?
No, depending on where you work, everywhere that I've worked, in my protocols, if the family requests that you stop, then you can contact a doctor and stop. And usually that's, I haven't ran into a situation where it's like, a kid and the family's like, stop, unless the kid's been like critically ill or like chronically ill. So yeah, if your family's requesting you to stop CPR, I usually advise them like, okay, I just need to call a doctor first. We're going to do very minimal things and then we'll stop with it. But most of the time you're not going to run into a lot of that unless it's like your older folks that say it's time. It's time.
What was the name of that cult? The HBO.
they called it, I don't know what the name of the documentary is, but they did do a documentary and I'm pretty sure it was on HBO. It was called like the 2x2s. We call them the snake eaters. But I don't remember, there was like an actual religion that they were like a part of. And it was like, I think a branch of like the Mennonite. Don't quote me on any of that, but I just know that they didn't believe in doctors. And I had 2 of them in my class in school because I went to like a little program town. My graduating class had 19 kids, so they're like, all right, here we go. So yeah. It was really interesting though, because they did a whole investigation because they found out that the coroner in, I think it was Canyon County, was like in on a lot of stuff. So they had like these unmarked graveyards of kids because they wouldn't report deaths because they were in the hospital. It was horrible.
That's wild.
I had a guy once, he snapped his femur like completely in half. He got hit by a car. He was out working on like signing on the roads. And he got hit by a car, femur's like, and he's like, I'm not going. And I was like, bro, your femur sucks right now. And he's like, oh, no, I'm fine. So didn't take him to the hospital. He had every right to refuse.
That's
Yeah.
just sit there waiting for it to pass out.
Yeah, basically.
Oh, they will pass out like, wow. He's like, ah. Go to the hospital.
Okay, let's go. Yeah.
Some things that you will see, you be like, listen, bro, like, you really need to do this. And they're like, no, I'm fine. I'm like, no. So just EMS is I'm pretty sure a simulation.
It is. Well, so one time Chaz and I were in his house, lady stroke, full on having a stroke. She's like, I'm not going with you at the beat, blah, blah. I'm like, okay, cool. So I'm on the phone with the doctor, like trying to convince her to go. And when I'm on the phone, like I pace like this, you know? And so I'm pacing and I step and I watch like a family of roaches like scatter away from me. And I'm like, ooh. So I look at him and he's like as far as he is now. And I look at him, I go, roaches. And he's like, huh? And I was like, roaches. And so he walks over to me and he's like, what? And I was like, roaches. He turned around, walked out the front door, didn't come back in. I was like,
Why roaches?
you don't like roaches? Yeah.
No.
Didn't even say a word. He just left. I was like, great. Thanks.
So in these situations with refusal of care, like, do they take a while sometimes?
Yeah.
Or most of the time, do they take a while? Like, we try to convince them.
It really
Much as
depends,
possible.
right? If I go out, because we get called, members. If I go out because, you know, somebody called 911 because you were asleep at the Dollar General, and I roll up and like tap on your window and you're like, my bad, man, I've been driving, you know, out of Salt Lake all day. Like I was just trying to catch me a little nap. Cool, man. You know what day of the week it is. Ask you a couple questions. Like, you want me to check your vitals? They're like, no, man, like I'm good. Cool. See you later. Right. On the flip side, if I go out and, you know, your blood pressure's 80/40 and your heart rate's 160 and you got a temp of 104 and you're like, no, freak you, I'm not going. Well, that might be a little while because we're going to sit down and have some conversations. It really is just situation dependent.
So that refusal of care form, even for that first guy, you haven't filled that out?
Yep.
So
Yeah, they're still going to get it, right? Like you're still going to have to refuse that care because you activated that system. So you still have to refuse that care at that point. Even if you didn't call, right? On the flip side, if you didn't call and somebody else called, and I get there and you're like, frick you, I'm not signing your paper. And Mr. Smithers back here, right? If you're able to answer all my questions, like you don't have to sign the paper. I'm going to ask you to, but if you don't, then I'm just going to turn around and look at Smith and be like, cool, man, like you signed this as a witness, like he told me to. And Smith's like, cool, yeah. And we all go our separate ways. So.
Yeah, and don't underestimate the power of a cell phone here, because people will call for the most random crap. They're like, there's someone dead on the side of the highway, and you get out there and it's just somebody that's been hitchhiking. Like,
They're just out there napping.
yeah, they're just chilling.
They're like, there's stuff scattered all the way down to I-80, and you get out there and there's like a bicycle and a backpack. Okay, and you're like, hey man, and he's like, yeah, yeah.
I always like the drunk person in the ditch.
Yeah,
Oh,
that was
yeah.
my favorite call.
Yeah, it always.
And half the time it was just
He
guy
fell
that
down,
passed out, fell down,
Yeah.
walking home.
Let them sleep, let people be, you know? Yeah, we run into that a lot. A lot of like ghost accidents, we'll get called for accidents, and then we'll be driving up and down the highway looking for them, and there's just nobody there.
Yeah, that's unusual,
Yeah.
especially a baby.
No, oh, yeah.
For the fire department, we get the same thing. So.
And I feel like they're always out there at that exit too. Like, I don't know if there's like a ghost vehicle out there or something, but.
That's usually people broke down, parked on the side of the road too.
Yeah.
I've heard some weird shit that's happened on
Pumpernickel's really, I've gone out there a couple times, there was nothing at that exit.
I've heard some weird stories about them.
Yeah. Pumpernickel's not a fun exit.
All right, communication and documentation. So, this is where we go into our charting. If you guys have that little handout that I gave you, you can refer back to it. You don't have to have it, but it's just whenever we start talking about like SOAP and D-chart and stuff, you can refer to it. It's fine. So our objectives, this is right about the time I figured out putting GIFs in the PowerPoints, so you're welcome. So review types of communication systems, overview of radio transmissions throughout the calls, learn charting standards and the layout of charting. Just know that charting is going to be different everywhere you go depending on what systems they use. So you're gonna get real comfortable with one charting system, and then you're gonna move, and they're gonna be like, here's a whole new one, and you're like, crap, I gotta learn this one. It doesn't take long, but you know, that first little bit can be kind of a pain in the butt. And then identify potentials for legal issues with improper charting. So charting is everybody's least favorite part of this job. It takes up more time than the call itself. Like you go run the call and it's a cardiac arrest, it takes you an hour and a half to chart it, and the call probably only took 30 minutes, you know. So just make sure that you're charting correctly. All right, so communication systems, we have our base stations, we have our mobile radios, like what's on the table over there, or portable radios, I'm sorry. Mobile radios are in the ambulance. The repeaters, like over here, the repeater, and then we use cell phones sometimes, and then telemetry. So certain places are able to transmit your like medical data for the patient that you're dealing with to the receiving hospital. So like if I do a toe bleed in Atlanta, you can send a picture of that toe bleed to the doctor, like wherever you're headed. Also, there's like stroke telemetry. So they have certain like apps and stuff that people are using these days where you can actually like video chat your doctor with your patient. Be like, okay, here's my patient, and they'll like do a little stroke assessment and stuff. So it's kind of cool to see how much stuff is advancing. Like even in just the 10 years I've been doing this, I've seen a lot of change, and most of it's for the better. It makes it easier for us, right? They like it. So these are our monitors. There's a button you push on here, takes the 12 lead, push another button, it sends the 12 lead off. Kind of fancy. They used to have a system like that out here at this hospital, but we got new monitors, and I don't think they cared anyway. But all right, so radio communication is regulated by the FCC. So basically, don't go cussing on the radio. That's it. So usually, most of the time, we're very like direct with our dispatch. We're not going to get on the radio and be like, all right, dispatch, I'm wearing a white shirt. The last time I ate was about 2 hours ago. There's a breeze about 2 miles to the east, and this patient, we're not going to do all that, right? We're going to keep everything short and sweet. It saves everybody's sanity in the end. So also prevents interference with radio traffic. That's still a thing. Like we still run into that occasionally. If we have multiple calls going out, people like to talk over each other sometimes, and most of the time it's not on purpose. Like you're just getting on the radio trying to talk, and someone else is doing it at the exact same time. So yeah, it happens. So radio communication tidbits. Whenever we're talking with dispatch or control, is what we call them here. It's a hey you, it's me system. I think it's opposite at the mines. So if I'm talking to Chaz, it'd be Chaz, this is Becca, right? So I think at the mine you guys are like, this is Becca, hey Chaz. I think it's how you guys talk on radio. I remember they were telling me that last year. So it's a control rescue 7, like hey you, it's me. So you start out with that. You don't go control rescue 7, blah 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 blah. You say control rescue 7, wait for them to respond, and then you give them what you're gonna say. So if you are transmitting a number like 15, it can kind of sound like 50 sometimes. So I say like I have a 34-year-old patient, that's 34. So just repeat the numbers. They prefer affirmative and negative rather than yes or no. And then times are given on a 24-hour time clock. So if you're not familiar with that now, whenever you start working in medicine, become very familiar with it. So. And most of the time, whenever you're talking with dispatch, you'll say, hey, dispatch, this is rescue 7, I'm on scene. And they'll be like, they'll just say the time instead of saying copy or whatever they're going to say. Or they'll be like 1712 or whatever time it is. They'll just give you the time. Make sure you're familiar with your agency's use of slang, possible 10 codes. Everywhere you go, they're like, we're getting away from using 10 codes, and then they use them anyway. And it can be kind of like confusing sometimes. You'll learn 10 codes. So like 10, like where I worked in Idaho, 1050 meant a car accident. So we got called out to a 1050. Out here they use 10 codes. You don't have to use them. Like if I'm going to call en route, some people are like, I'm 1023 or whatever it is. I say en route because I don't have to. We try to avoid 10 codes in EMS, but they pop up. And then, yeah. So if you are giving a radio report to like the hospital, out here we give radio reports. Try avoid using like what you like a diagnosis, your field diagnosis. Like if I think somebody has appendicitis, I'm not going to call in and say, I have a 28-year-old male with appendicitis. I'm going to say abdominal. So that's just kind of how they want you doing it. Does that get mixed up? Yeah. Yeah, it does. All right, so dispatch, we like our dispatchers out here. They're great. They help us a lot. And they're pretty nice people. So we like our dispatch, but they will record all of the times for you. We get a sheet at the end of the call, it's a CAD report, and we get all of our times. So if we're not time stamping stuff and we call on scene or whatever, they'll put all of that in a form for you so you can just relay it back into your chart. Whenever you leave the unit, please carry a portable radio. Whenever you guys are doing your ride-alongs, we have extra radios. If you want to snag one, just make sure you give it back by the end of shift or whenever you leave. Because if something happens while we're out of the unit for whatever reason and you need to get a hold of somebody else, I'm not going to call 911. I've had stories of people getting beat up in the back of the ambulance. Neither partner had their radios on them. They were in the back, so they couldn't use the radio in the front. So the girl called 911.
Person sleep.
What's it for?
Uh,
Oh, that guy. I don't know what I was saying.
Getting attacked in the back of the ambulance.
Oh, yeah. So this chick was getting attacked in the back of the ambulance. They busted out the window, and she didn't have a radio on her, so she called 911 on her personal phone. It was like, I'm unit, whatever. I'm getting beat up by a patient. So make sure you keep a radio on you for stuff like that. That really doesn't happen out here, but you never know. So radio medical reports in our little jurisdiction of Nevada, whenever we give a report to the hospital, it is over radio or a recorded line. Apparently somebody at some point called and asked for orders from a doctor. The doctor gave them orders. The patient suffered because of it, and then everybody denied that the orders were given. So now they're like, we'll just record everything. So our radio channel is recorded whenever we give a report to this hospital. We talk to them the same way, like the MGH, this is recipe 7 for a radio report, whatever. So it is structured to present the most important information. You guys have that handout sheet that I gave you. The radio report should be short and sweet. We don't want to give them all of the information that we have over a radio report. We're giving them the gist of what's going on. And then whenever we get to the hospital, then we can give them their whole life story. Right? So don't be on the radio like, oh yeah, this 27-year-old, when he was 3, he had surgery on his left ankle. Now he's 28. He missed his 5th birthday party. Don't do all that. So just keep it short and sweet. That handout I gave you, if you practice it, whenever we start running scenarios at the end, if you look at those medical sheets I gave you, at the end, you have to give a report anyway. So why not practice now, right? In the classroom. Oh yeah, don't give a patient name over the phone or the radio because other people are listening. So sometimes they're encrypted, sometimes they're not, but just make sure you're not like, oh yeah, I got Geraldine out here. That's not cool. All right, so medical direction, sometimes you'll need to call for medical direction depending on where you work. An example like out here, if I need to bypass this hospital, I need to call for medical direction to bypass my closest hospital. I have to get permission from this doctor that's like, yeah, take them to a trauma center or wherever I'm going to send them. So make sure whenever you're calling for medical direction, you're painting a picture of your patient. So you're giving them all the information that you're looking at, and then you're saying, this is what I want to do. And then they'll repeat to you like what you want to do. They'll give you the orders if it's like a medication or something. And then after you receive those orders, make sure you repeat it back to the provider on the phone. Like, okay, you said to give 324 milligrams of aspirin. and then they'll say yes or no. So it sounds like a lot, but this whole closed loop situation, closed loop communication, you're gonna see as a common reoccurrence throughout this class. You'll see it in CPR. They'll be like, make sure you use closed loop communication. But it is important because things get lost, right? So you got a lot going on, you're calling for orders, the doctor may misspeak. And if you have any questions about what they're telling you to do, make sure you question them nicely, but question them. Like they're like, oh yeah, go ahead and give 3 of aspirin. And I'm like, okay, 3 milligrams of aspirin doesn't seem right. Like make sure you're correcting them or clarifying, because you don't want things to go south because somebody said something wrong and you were too scared to be like, that's wrong. All right. So the verbal report, this is what you get once you get to the hospital. There's going to be 100 different scenarios where either your verbal report's pretty chill, you're just standing there talking to a nurse, or sometimes you get put in a trauma bay like this and you're yelling over like 67 providers and you're trying to tell everybody what's going on. It can be difficult, especially for somebody that's like quiet, like myself. That's something I had to learn. I learned to stand next to the computer lady so she could hear me the most clear, and then I just screamed my report because there's so much going on. Some places have a timeout report, and I feel like every place should, but not every place does. So timeout report is where everybody in the room is silent while EMS gives their report. It should be this way. It's not this way everywhere you go. So they give you 30 seconds, which does not seem like a lot of time, like talking about it, like 30 seconds is nothing. But to give a full report, it should really only take 30 seconds. So I like to use the MIST. There's eMIST, whatever. If you get a way that you like saying in a report, stick with it. Muscle memory is a great thing. So the mechanism, like what's going on with, or what happened to the patient. This is their chief complaint. This is what I did. This is their signs and symptoms, that kind of thing. So make sure you're reporting any medications given. Make sure that if you don't do something, tell them why you didn't do it. So like if I brought in somebody with chest pain and I didn't give aspirin because he's allergic, I'm going to tell them that. I'm not just going to leave it entirely out of my report, because then somebody's going to walk in with aspirin and say the guy's allergic to it and that's why I didn't give it. They gave aspirin, that's the problem. So make sure you're just communicating really well. This can be a hard thing to kind of get used to. Because a lot of times you're talking with strangers and you're usually doing it while the patient's sitting right there. Sometimes it can be awkward because the patient's like, oh yeah, actually this. Because patients love to be like, oh yeah, I passed out and hit my head. And then you get to the ER. I never passed out. I never hit my head. But it happens. All right, so communication, again, you're going to hear closed loop communication 100 million times in this class. So closed loop communication is where if I speak to Chaz, like, hey Chaz, go ahead and pull up 150 milligrams of amiodarone.
150 milligrams of ammo.
Yeah, with the cough drop in and everything. So team communication is obviously very important. We want to be able to communicate with our partners, with the people that we work with, all that jazz. So speak respectfully. And then there's something called therapeutic communication. This is great for a lot of patients. So it's 7. It's a test page. So if somebody's really hyped up, really anxious, having a hard time, sometimes you can use therapeutic communication to calm them down. It's actually great. It works a lot of the time. Sometimes you can't talk somebody down. Sometimes you talk them down for about 4 minutes and then get right back to where they were. But just practice that. Like if somebody is hyped up or anxious or even angry on a scene and you walk in and meet them with that same attitude, it's just going to make everybody's day worse. So try and practice therapeutic communication, talking calmly, being able to talk people down. That's an important skill to have in this field. So make sure you're using effective, use eye contact. Don't be weird about it. Don't be like, listen to me, lady. You know, so don't be that person. Make sure you're honest with your patient. If something's gonna hurt, tell them it's gonna hurt. Especially kids. Like if I go to do a blood sugar stick on a kid and they ask me if it hurts, I'm not gonna be like, no, it don't hurt, and then stab them. That's rude.
Like, I wouldn't want somebody to do that to me, so be honest. And then be aware of your position and body language. This is a pretty interesting thing to read into. So there's a whole book written by a guy that worked for like the CIA. He was a body communications expert. His name was Joe Navarro. The book is called What Every Body is Saying. So he goes into like how we present ourselves on a day-to-day basis, what our body language says to people. And the big thing that I took away from reading the book is like anytime you stand above somebody, you're like trying to do like I'm in charge kind of thing, right? And so whenever you're talking with your patient, it's important to make them feel comfortable. And one way you can do that without just like talking to them and trying to make them feel comfortable is like getting on their level. So obviously if it's a psych patient, I'm not gonna like get on their level because I don't want to get punched in the face. But if it's like Granny, I'm gonna kneel next to her recliner or whatever she's sitting in. Make sure you are mindful about where your hands are. So any kind of barrier from your hands to your patient or whoever you're talking to, like if I have my hands in my pocket, it shows that I'm not interested in what you have to say. And if I'm showing up to your house because you are sick and you called me, you would want me to be interested in what you have to say, right? So I don't know, that's another one of those things that I'm weird about. But just be aware of it. Don't walk in like somebody. Nothing like that. So like this, got on Granny's level. You'll like to see it. Some people are really touchy.
The dementia granny's got a mean right hook.
They do. They do. Just whenever they pull off their like sandal.
Yeah.
Chocolate.
They'll get you.
I will.
Don't let granny pull you. That crap hurts.
Yeah. So if you were to walk in, or this doctor was to walk into your doctor's office, and you're not feeling well, and he looked at you like that like welcome me? No. Like, okay, bro, you want a box? Like, what's going on? You know, they'll go. Yeah, I don't feel good right now, but you're take you out to me. So just be mindful. All right, use language your patient can understand. We're gonna get through the medical terminology next Tuesday. We're gonna use words that you guys don't know, but we're gonna learn them together. But if I come at you with, oh yeah, like if you're sick, and I look at you and I say, well, your carine is definitely bifurcated. In the left mediastinal aspect of your meninges, you're gonna look at me like, what did you just say? Like I'm dying, you know. So make sure you're using like common language. You don't want to just walk in just throwing medical jargon at people. It makes you feel smart if you say a word that somebody else doesn't know, but that's not cool with your patients.
Don't say something if you don't know what the frick you're talking about.
Yeah.
You're gonna look like a ding ding. I promise you, you're gonna look like a ding ding in front of somebody. So if somebody's like, what does this mean? And they hand you a medication. They're like, what is this for? Like the doctor prescribed it. If you don't know, you're like, I don't freaking know.
Let's
Let
get
me
bullied
look it
together.
up, right? I can promise you they will. It happens to me. It happens to Becca. Do not be embarrassed by saying, I don't know.
Do not
Right.
be a ding ding.
I have watched doctors on Google things. We don't know everything. We'll figure it out. We don't know everything.
Except Calvin.
Well, Calvin's special.
Different. Make sure you're explaining procedures. This is a big thing, especially like whenever we're dealing with like time-sensitive emergencies. We kind of get wrapped up in like not explaining to our patient what's going on. This is something that you might see. Like for example, if someone's having a heart attack here, I've seen this multiple times. I know what's going to happen. I know what's going on. The patient usually doesn't know. They don't know that once we get them into the Elko ER, they're going to strip them naked and start shaving their genitals. Like nobody knows that. And then usually the people in Elko don't tell them what's going on either. So they start ripping clothes off and they like start shaving and the poor patient's sitting there like, what the heck's going on? So make sure you're explaining procedures, even if it's something as simple as I'm going to take a blood pressure off. They don't know what that is, especially kids. They're scared of it, right? So explain it to them. Use the patient's proper name. We say this, everybody. I love everything. So.
And I do it in front of her, so I don't get.
Patient,
He's like, all right, babe, step on right there. And her dad was standing there. It was like an older lady, but her dad was there.
Yeah.
He's like, don't call her babe unless you
That's
plan on
my
taking.
daughter. And I was like, that's cool, bro. This is my wife. Come on, get in the truck.
The little old ladies love it. They're like, oh, the sweet son of me, call me babe. It's funny. Make sure you're listening to your patient. Another thing, whenever we are learning to ask questions and get information from a patient, that's one thing we forget as well, is like you get so wrapped up in like your OPQRST, and you'll learn what all that stuff is later. But you get so wrapped up in asking these questions that you forget to like hear what the patient is responding with. So you're like, when did this start? How long's it been going on? Has this ever happened to you before? You taking medication for this? And they're like, yes, yes, no, no, yeah, yeah, yeah. And you're like, I don't remember anything that they said, but I know all the questions I asked, right? So make sure you're listening to your patient. There's a Dr. Ginger Locke. She likes to call it listening in color. So you talk to your patient, you ask a question, you give them time to respond to you, and then you ask your next question. Because if I go asking questions and cutting the patient off, I'm not really getting the information that I know. Right? So if I say, like, for example, if I ask Granny, how long haven't you been feeling well? Do you feel sick? How long have you been sick? And she says, well, I didn't eat lunch yesterday, and it started out, and I took my medicine this morning, and da da da. Like, give her time to answer, because then, okay, what medication? You can ask more questions. Be compassionate and respectful. And then pediatrics, they're tough, right? Kids are scary. And so come down to their level. Again, be truthful. Don't be like, I'm not going to hurt you, and then go stab them. That's not cool. But pediatrics, another thing of like your assessment we'll learn later is like for an adult, you usually start your assessment like up high and go down low. For kids, start at their feet and work your way up. You got to earn trust with the kid. So just keep that.
I was told something about a decade ago by the person that taught my EMR class. A patient's not going to remember you by how stupid you are, but how you act. So you can walk inside of a patient's house and be the dumbest person in the room, and they're not going to remember that. But you can walk in there and be the biggest dickhead in the room, and they're going to remember you. I can tell you firsthand that me and this young lady have walked into many restaurants in this town and gotten hugged and patted on the back and everything else just because of how we treat people and the things we say to people. That's what they remember. They don't care what, most of them don't care what you do in the back of the truck because they don't know what the frick's going on. All they care about is how you treat them. So be mindful of that. If you act like a dick, we're going to hear about it. I promise you.
All right, so pre-hospital care report, or your PCR, is what you'll hear most people refer to it as. So this is our written documentation. So whatever happened on a call is written down in some manner, whether it's written, physically written. I don't work for a place that actually does that. We have tablets, computers, that kind of stuff. So document findings and treatments. So you document your assessment, what you found, how you treated it, and how they responded to your treatment. So I could walk in, they're being wheezy, they can't breathe, and I give 2 albuterol treatments and they get better. If I don't document that they got better, there's going to be questions brought up later. So make sure you're documenting what you see, how you treated, how they responded. This is a legal document, so any of it can be subpoenaed at any time. That includes like QA, QI messages. So if you ever work for a system that somebody reviews your charts and gives you like feedback on whatever you charted, any of those messages can be pulled and subpoenaed. So if you go right.
Yeah, I have a lot of reverb.
Did they write in the chat?
Maybe. If they did, I have to exit out of this. What happened?
Okay. It's just like just like
I don't know why it popped up so much
the message. All right, so yeah, so don't, if someone writes you a QA message in your chart, we'll talk about QA. Don't respond like using foul language. Still be professional because all of that can still be something. So, again, if it isn't charted, it didn't happen. So your chart gets subpoenaed later, and they're like, "Well, why didn't you do X, Y, Z?" And you're like, "But I did." If it's not in the chart, it didn't happen. So formats. Whenever you guys are in your clinicals, you will be writing charts on your patient contacts. I'm not going to give you like a 10-page form to fill out for each patient. I just want you guys to write like a simple narrative, and you can use those SOAP forms that I gave you. There's a couple different formats. So D chart's another one. I don't care which one you use as long as you have the information in there so we can review it and talk about it. I like using D chart. That's just what I grew up on. So the D is for like dispatch information, your C is your chief complaint, H, history, assessment, your treatments en route to the hospital, and then any exemptions. So like if I didn't do something, why didn't I do it? Chaz likes using SOAP. SOAP is also very simple. So we gave the handouts. If you want like extra like handouts for like a D chart or whatever, if you want to do it in chronological order, I don't care. Just as long as you have the information in there and it's in some kind of, like it makes sense. You know, that's all I care about. So SOAP is pretty easy. It's your subjective. So if I walk in and the patient says, my chest has been hurting since yesterday, that's a subjective thing. They're telling me what's going on. Objective is something I can see. So their vital signs, if their skin color looks like that, if it's whatever, right? If I can see it, it's going under the objective. And then your assessment and plan. So this is my assessment, this is what I've seen on the assessment, and this is how I'm going to fix it. And this is what I did to fix it. That's all part of your assessment and plan. All right, so pre-hospital care report, PCR. So administrative data. So there's also there's spots to put insurance information in, the billing address. So some people's billing address is different than the address you pick them up at. That all goes in there. We scan face sheets into our charts, and that has all of that information on it. So all of their insurance information is all in their face sheet, usually. Your charts can be used for education and research. So the state, it all goes, so by the time you finish a chart and it goes from like you to the state to billing to whoever else it needs to go, insurance, there's like upwards of like 50 something people that look at one chart by the time it's all said and done. So don't sound like a baby in your charts. But it is used for education and research. So I think the next slide has a picture of like the formats we use. There's some weird little click boxes that we'll click, and we're like, why are we clicking this? Like the patient race, like why is that important? You know, but they use that for data and statistics later on down the road. So all of that can get pulled. This is what our PCRs can look like as they're pulled up in like an all done form. So like when we see it, it's all click boxes, and then once it's all filled out, it'll pull up a sheet like this, and that's what billing looks at. And they'll read the narrative or whatever you wrote, all the vital signs, whatever. And then you have your QI, so your quality improvement. Usually you have a team that you work with that will review charts, and they're not always buttholes. I know that you're going to get a message one day, you're going to be like, this person's mean. They don't mean it to be mean. They want you to be better. So they want somebody to review their chart, be like, this is what we did good. This is what we could improve on. This is a consistent issue with everybody, or everybody's doing really good here. So these are reasons to like look at charts. This is what ours looks like. I just Googled image trend, so I don't know if these are actually in relation to anybody. But these are what ours look like, except we have a lot more of these little blue lines here. So you just put in all of your information. But this is what I was talking about, like the weird stuff that you might not like. Why are you putting this in here? So like your primary action taken, there's usually like a number assigned to it, and then like we have to give 2 like differential diagnosis on our charts. Okay, that's kind of odd, but it all goes back to numbers and statistics and pulling things. So Our run data all goes in there, so you'll get these little numbers, your incident numbers. That all needs to be put into your chart, so it can be referred back to and found. Yeah, charting takes a while.
Yeah.
All right, so confidentiality we talked about in the last chapter, so that's all covered by HIPAA. Our patients sign a HIPAA form whenever we drop them off at the hospital. Just saying we're not going to share any of their personal information gives us a right to bill their insurance, all that stuff. We talked about the patient refusals, very high liability. Make sure you document all details. So I wouldn't just put patient didn't want to go because they said so. There's a lot more that goes into that.
Rachel will be here in 1950.
And a 15. Okay, thanks. All right, so falsification, make sure you're charting correctly. Don't try to cover up your errors. If you do make a mistake, for whatever reason, whether it's a med error or anything, do not try to hide it. You're going to get far less repercussions if you go tell the person, your boss or whoever, that this happened, so corrective like actions can be taken, than if you were to just try to hide it. So, and it's scary. I've had a medication error before and I was like, oh crap, this sucks. And I ran over and I told the doctor, I contacted my boss, I let everybody know what was going on. This is why it happened, this was a medication error, but you know, I didn't get fired for it because I didn't try to hide it. So it happens to everybody. And if you ever think it's not going to happen to you, those are the people that it happens to first, I feel like. So, special situations. So for documentation, MCIs, multiple casualty incidents, can be odd because there's so many people and I'm not going to run around being like, okay, what's your social security number? What's your insurance information? To everybody. It's not feasible. So we have these. We'll talk about them more in later classes. They're triage tags. So once you learn to triage, you can write some information on those triage tags. There's numbers associated with them, usually right around here. And that's how they all get put into a system. It's just like a giant, like everybody gets a tag. Now you write like a summary of like stuff that you did, and then they can pull tags later. So again, if it's an MCI, I'm not worried about getting everyone's name, date of birth, history, allergies, none of that. If you have an exposure to an infectious disease, that's a special situation. So obviously you're going to want to report that to your employer, or if there was an exposure, they'll report it back to you. If you have suspicions of it, like say that someone's like, yeah, everybody in my family has tuberculosis and now I have a cough and now you go on this patient, like make sure you're documenting all of that stuff. If you injure yourself on a call or your partner gets injured on a call for whatever reason, that needs to be reported. And it needs to be reported immediately. That's not something you wait 2 weeks and you're like, oh, actually it got worse, I'm going to report it now. You need to report it whenever it happens. Hazardous or unsafe scenes. That's something that can take a while to get on scene because the scene's hazardous for whatever reason. We've had a couple instances out here where it's like hazmat situations, you know, working with like stuff out here. Certain like accidents may. We had one that was
Possible cyanide too. Oh,
yeah. So we're not running up there. We're like, yeah, cyanide. No, we're gonna wait. I do the thumb thing. If I can cover it with my thumb.
just remember, when you're on an ambulance, especially when you're working for an agency like this, we are not hazmat. I have hazmat tech in operations from the fire department. I am not a hazmat professional when I work on this ambulance. If you're working in Elko County, you are not a hazmat professional. Let them people do their thing and you stay back and let you do your thing. Even if you've got the certifications, when you're working in this world, you're not certified.
Yes. So referrals to social service agencies might require some additional paperwork, and the mandatory reports are always going to require additional paperwork. Yes, you are going to put it in your chart, what's going on, that you reported it, but there's still like websites and forms that you need to go through.
What are your top 3 things you try to get from a patient in a mass casualty incident?
Usually, like beyond triage, like are you breathing? Are you alive? Are you here?
ABC.
Yeah, so like beyond the triage things, I would try to get like any intervention done. So like obviously like there's a tourniquet on their leg, and right now. Maybe a name, I'm not really with that. Previous interventions and what they were like triage wise. And if you go back to re-triage a patient, they change. You want to do that. We'll talk about that more in like in the last chapters. We'll do a big triage thing with y'all because triaging is fun. It is a good time.
So, real quick before y'all leave out of here.
Are we flying up?
Yeah, it'll be here. Oh. So, and this is gonna be kind of hard to read, but I just wanted to talk about this real quick since we keep bringing it up. So this happened in 2023. This was an incident involving a Sioux City, however the frick you say it, Iowa. She was an Iowa paramedic that went out to a 26-year-old, and he was combative. She went to give him a medication called ketamine, accidentally give him a medication called rocuronium, which paralyzed his entire system. He stopped breathing, went into cardiac arrest. She failed to notify the receiving facility that she gave that medication and failed to notice the cardiac arrest. He ended up having what they call an anoxic brain injury, which basically means his brain was so deprived of oxygen that it was dead. And he died a couple of days later. She entered into a non-guilty plea February of last year. Pre-trial started in July, but she's being charged with involuntary manslaughter. What got her charged with involuntary manslaughter was her inability to recognize what she did in a timely manner, and her not reporting that situation to who she dropped it off to, right? Because theoretically, if I give you rocuronium right now, I can stop you from dying. All I gotta do is breathe for you, because all I'm doing is taking away your ability to breathe. If I breathe for you, you don't die, right? Now, if I give it to you in error and I breathe for you and you don't die, I'm probably still gonna be in trouble, right? Because there's a giant label on the top of this thing that says paralytic, and there's all kinds of warning labels all over the side of this medication. So I'm probably still gonna be in trouble, but I'm not gonna be charged with manslaughter. And so she's probably gonna do a decent amount of time in jail. And simply because she didn't notify anybody and didn't correct action. And that's it. All she had to do was fix the problem and tell somebody she did it, and she would have been fine. I mean, she probably wouldn't have a job, but, you know, it's better to be in jail. Yeah, I mean, he probably would be dead. So that's what you got to think about when you do this. It's okay to make a mistake. As great as she is at what she does, she's made mistakes. As terrible as I am, I've made mistakes, right? So just remember, you're going to make mistakes. If you do this job for any length of time, or if you meet somebody that does this job for any length of time and they tell you, well, I've never made a mistake, they're a dirty liar. And tell them they can come talk to me, because I'll tell them they're a dirty liar. You're going to make mistakes. Owning the mistake is part of the process. Learning from the mistake, trying to do better next time and not doing it again. I've made merit errors. Luckily, mine have been benign and haven't hurt anybody. Becca's made med errors. Luckily, hers have been benign and haven't hurt anybody. But we went forward and was like, oh, yep, I did this. Whoopsie. And nothing happened, right? We kind of got a slap on the wrist and moved on. So keep that in mind. Cool. Any questions?
class this weekend. Homework due Monday, Wednesday. We'll have a test on Tuesday when you get here. Everybody signed up for the state, so we're good there. Cool. Well, everybody's gonna have to be here next Tuesday, so be prepared, or next Saturday, I'm sorry. So, y'all ain't got no questions? Got anything else?
No.
Good?
Thanks, guys.
Cool Sunday.
Yeah, don't get too drunk and call it.
Don't-
So I'll be at work, so.
That's my favorite.
So good.